Thanks everyone for coming tonight after your busy days. Now, I thought I'll just present a case which I think most of the endocrinologists might see once in a lifetime. I thought I would not bore you with Graves' disease or Hashimoto or tell you about the physiology of the thyroid, what is TSH, what is T3, because I think that would be, you guys are overqualified for that. So let's talk about something interesting that I have found. So it's a case study of a 19-year-old boy who was referred by his GP to me. And these were his thyroid function. So he's presenting with the high T4, and this is on 2 occasions, and TSH has been 5.62, and then it was 2.84. And his TP antibody was above 1300, which was pretty high. So initially I thought, well, this is another, Hashimoto, high TP antibodies. I said to the GP, okay, let's repeat it again in 6 weeks' time. Look at the boy clinically. And boy was pretty lethargic when I saw him. He did not have any symptoms or signs suggestive of a transient thyrotoxicosis or hyperthyroidism. Very lean. I would say a bit slow in his reflexes, occasional constipation. So he was sort of giving you the signs and symptoms just of subclinical hypothyroidism. So I sent him back, and when he came back, his T4 was still 25.4, and his TSH was 2.84. So I went on and I did a technetium uptake scan, and that was pretty normal. There was no sort of hypo or hyper uptake. There was very normal uptake on the scan. His TSI and TRAB both were negative. So with a normal scan and a negative antibodies, we have excluded Graves' disease there or any toxic adenoma as well because the scan was normal. Then we have another set of thyroid function. And at this point, I was still thinking, well, sometimes you are in the recovery phase, so the technician scan may deceive you. So I repeated the thyroid function again after 6 weeks. And we get another set of bloods here, which is showing you high T3 and T4 and a normal TSH. Any thoughts here? What's happening around? So when we have hyperthyroidism, obviously the TSH is suppressed. When we have hypothyroidism, the TSH is up. Now in this kid, we have high T3 and T4, but the TSH is still normal. And if you go back, the TSH has been up, then it comes back to normal. And then look at the T4, it never becomes normal. Not at all. No localized thyroid signs. So I would be thinking that, these thyroid functions should be suppressing this TSH as a negative feedback, but it's not happening yet. Any thoughts? That's what I thought. And I kept on repeating it before I exposed this little guy to the MRI scan. So, and after 4 weeks, I did another thyroid function. Not 4 weeks, but he went to Pakistan. He's from my country. I know we are very rare. So, so he went to Pakistan and then he came back, and his father told me, look, he is not the same. And I've tried a few things, and his father was scolding him for being lazy and all this stuff. And we repeated the thyroid function, and you see the T3 hasn't moved. The T4 is almost the same, going up and down. At that point, I thought, well, am I missing a pituitary adenoma secreting TSH and causing the thyroid function to go off, which is TSHoma, we call it. Then I did a pituitary MRI, and all we found was Chiari malformation, no features of pituitary micro or macroadenoma. I discussed with one of my colleagues in neurosurgery. They said they're not worried about the type 1 malformation. They're not actually worried about this scan. Now, where we go from here? So it's not Graves, it's not Hashimoto, it's not pituitary. Now I'm scratching my head. What is happening with this kid?
Is it somebody else's medication?
No. So no one in the house was sort of using. I mean, and it is, the picture is not actually, exogenous thyroid administration.
Is there any other problems that mimic thyroid? TSH? Can it mimic that?
So clinically, on a thorough history, there was no sort of suspicion of any malignancy or a paraneoplastic phenomenon. All right. And then see, but I never gave up. I kept on repeating the bloods, hoping that something might change. Okay. Now then I thought this kid has thyroid hormone resistance. This is an extremely rare condition. And then I sent him for genetic testing for the thyroid hormone resistance A and B. And then we have another type, which is non-TR RTH, for which we have not yet identified the genes. So which compromises 15% of patients. So this kid had non-TR resistance to thyroid hormone. And obviously I had a chat to the genetic pathologist, and she was of the same conclusion that definitely this is thyroid hormone resistance, but we do not know, those genes are not yet mapped. So just giving you a quick overview. So thyroid hormone, we have the TRH, which comes from your hypothalamus and it comes to your anterior pituitary, and TSH is secreted from the anterior pituitary, and we make thyroxine, which is 80% T4 and 20% T3. But when it goes into the cell through this transmembrane receptor, we have 5-deiodinase, which take the extra iodine ring from the T4, and you have reverse T3 and T3, which is the active form of the thyroid, and then enters the nucleus with more receptors of the target cells. And then there is a lot of, by molecular messenger RNA level changes, and you have transcription, and that's how the whole function happens. Now, in the thyroid hormone resistance, where do the problem lies? So the problem can lie at different levels. So the problem can lie at the level of the thyroid hormone cell membrane transport defect, which is here. So in this situation, you will expect that the T3 and T3 is high and low level of T4 in this situation. And the reverse T3 will also have a psychomotor, deficit. In terms of the level of deficit at the metabolism level, you will see that there would be, defects which are involved in the enzymatic deiodination reaction, and which can cause diminished production of T3 and the reduced availability of T3 at the level of the target organ. If we go back and see, so if you have a defect at this level, then obviously the target organ is not sort of responding to the T3, because you do not have active T3 available to work here. And remember that it is the active T3 that goes for the pituitary level to provide the feedback. It's not the T4. You have more receptors at the pituitary level for T3. And that's how, and that is the basis of these thyroid function tests, that when you have resistance, actually the pituitary does not know that you have resistance at the peripheral level, and it keeps on secreting the TSH. But clinically, at the target level, the T3 and T4 are not working because there is resistance. Does it make sense? And because it's not working at the target level, so the T3 cannot tell the pituitary as well that, everything is going fine. So, sorry, that things are not going fine. So that's why pituitary assumes that whatever the pituitary is doing is fine and keeps on secreting TSH, assuming that the supply and demand balance is absolutely fine, but actually it's not. And that's why this kid was very lethargic, because I mean he's secreting T3 and T4 in big numbers, but they're not working because at the level of the target organ there is resistance to the receptors, to the action. And then you have, okay, I spoke about these two. Now, thyroid hormone action defects. No patients have been identified in this regard in the literature yet, which is the abnormal hormone transfer to the nucleus. When you enter the receptor and then the T3 works on the nucleus, on the DNA to, do transcription of the messenger RNA so that you can form some proteins, and hence the action of the thyroid is completed. However, in literature, we do not know. They may be, but they haven't been identified. In the TR, which is the thyroid hormone receptor, we have identified 3 types, which is alpha, beta, and non-TR, which is not being mapped yet. Now, RDH beta is amongst the thyroid hormone resistance. 85% of them consist of the RDH beta. And all tissues that express RDH, the TR beta, have reduced sensitivity to action of T3. And the resistance of the pituitary thyroid to thyroid hormones resists the TSH secretion, as I said, because it's not working at the end organ level. And hence it increases the secretion of T4 and T3 from the thyroid gland. And the elevated level of these hormones fail to downregulate the hypothalamic pituitary thyroid axis. So clinically and biochemically, RDH beta would be similar to this boy, but because there is no mapping for those genes yet, but the biochemistry is almost the same, which is quite different from the RDH alpha. Okay, I'll just finish this one first. So most patients are clinically euthyroid, but this chap was having subclinical euthyroid symptoms, which is possible as well. And the level of tissue response does not always correlate with the serum T3 and T4 concentration, because we must remember that the defect can be homogeneous or heterozygous as well. So sometimes some of the tissues at the end organ may be responding and some of them may not be responding. And hence some people are completely euthyroid and some people have subclinical hypothyroidism because they might have a more severe form of a defect. I'm coming to that at the end. The lab findings, as with this case, high T3, T4 and normal to high TSH. And again, clinically, they could be anything, which actually creates a management issue. I have, tried to contact big thyroid centers in the US. I wrote them emails, and they said sometimes to overcome the resistance, they have tried huge doses of thyroxine, like to oversaturate the receptors, stuff like that. I have tried that on this boy, nothing happened, nothing changed. Then I thought I'm just, poisoning this boy, so I stopped doing anything. Because unfortunately, nothing works for these guys. And then I told his dad that it's not him, unfortunately. It's a problem with the boy. That's why he's sluggish. This problem actually starts from the birth, when they are in the womb. And that's why these kids are born with a less IQ, a bit slow in their reflexes. And that's what the dad told me, that since childhood he's been like this. His other siblings and everyone are pretty good. So now after 19 years, the family knows that it's not his fault. Again, differentials, you could have pituitary adenoma. You can do a pituitary MRI, which I did. Clinically, they are hyperthyroid, because if it's a pituitary adenoma, obviously the clinical picture would be like grapes. You can be more, adventurous. You can do a T3 suppression test, but I don't think we have enough resources here. And the basis of doing a T3 suppression test is to differentiate a pituitary secreting adenoma, the TSH secreting pituitary adenoma from thyroid hormone resistance. In T3 suppression test, you give 200 microgram of T3, and then you measure the TSH response after that. If it's a TSH-oma, the response is blunted. It doesn't suppress. But you get variable response in any form of the resistance. This slide is not very clear, but what I'm trying to say here is The top one is when a normal patient has given, sorry, this one. This one is that, when you give the dose of T3 to a normal person, and you see that the dose is 0, which means when you inject a placebo in a patient, you get no response in TSH suppression, because obviously it's not going to suppress your TSH. Then you have different doses, 50, 100, and 200. And you see in a normal person, at any dose, when you give T3, it's going to suppress the TSH. The TSH is on the left top panel, sorry, the vertical axis. Now, in patients with both the beta receptor resistance and the non-TR alpha resistance, you see that the responses are not blunted. They still get some response in TSH suppression. So that's why sometimes it can become difficult to differentiate between these and the TSH-OMA. But with the normal pituitary MRI and no clinical features of hyperthyroidism, I was pretty confident that this is not TSH-OMA, even at the microscopic level, which cannot be identified by the MRI. So that's why I did not proceed with the T3 suppression test. And I was very confident that this is the diagnosis. But the unfortunate thing is that it is very academic. However, it is a diagnosis for this poor kid, and the family knows what his limitations are now. They're not going to push him too much. Obviously we can't do anything about it, but at least we have given him a diagnosis, and now people know what he can do and what he can't do in terms of his IQ, his intellectual function, and his physical abilities.
So, Dr. Badshah, there was a question on chat.
Yeah.
Chat said, when, if ever, is it appropriate for a GP to prescribe a T3 supplement?
Okay, so we have a question that when should we prescribe a T3 supplement? So I would say in my practice, less than 10% of the time, given T3 prescriptions, specifically in patients who I have ruled out all the other causes of, hypothyroidism-like symptoms, because we know that there is a very small subgroup of patients in which there is, a defect in the conversion at the molecular level between T4 and T3. They do not come in the spectrum of thyroid hormone resistance, but they need more T3 to be active. So if someone who has low T3 on the biochemistry and they have symptoms of hypothyroidism despite being on thyroxine, then I give them a trial and see how it goes. But that is a very select, patient population, not most of them.
How do you overcome the Medicare restrictions? Like for us GPs, we are told to do TSH. If that's abnormal, then proceed to TSH and T4. And, you don't get rebates for doing T3 at our level. And the patient clearly has symptoms of hypothyroidism because, their T4 is on the lower end of normal. The TSH is hovering somewhere in between the normal range, but they have obvious symptoms of hypothyroidism. That's why it's very important to know what kind of questions to ask when you're suspecting hypothyroidism.
Absolutely, very good question.
And when you do the T3, it's low. It's 2 point something. And I don't know when Medicare is going to come after me, but that's how I discovered a couple of patients with normal T4 and TSH with low T3.
Yeah, so I will just answer the second part of the question first. You have raised a very good point, is sometimes the TSH is normal, but the patient still have the symptoms. Now, we need to realize that the range of TSH, which is 0.5 to 4.5, where is it coming from?
Sick people.
Sorry?
Sick people.
It's coming from healthy people. Yes.
You're assumed to be healthy.
Absolutely. So the way the lab actually come to these normal ranges is, these are the 95% of people who stay between this range. Now, we always fail to recognize that there are 5% people who are out of this range, but they are still normal. Which means there are 2.5 here and 2.5 here, both ends of the spectrum. Now, that also means that if someone's TSH is 2.5 and they have symptoms, means that maybe they feel really good if their TSH is 0.4. Does it make sense? Or you can turn it around on the other end. They might, feel much better when their TSH is 5. So there is, I often do that. Sometimes I have there's a young girl, she's 22, and she has a history of lymphoma. She's a childhood survivor, very physically active girl. She does a lot of gymnastics and she works in circus, physically very active. Now she came to me and she said, like, I can't do anything in life. I'm sleeping all day. I am a gymnast and I was physically so active, and over the last few years, I can't do anything. I'm like totally morbid now. And I was initially worried that maybe it's the lymphoma coming back. And I said, when was the last time you saw your hematologist? And she said, well, my appointment is coming. She went to the hematologist. He did a battery of investigations. Everything came back normal. No lymphoma coming back. It's in remission. Then I started looking at her thyroid function over the years. Her TSH was slightly going up. It was still in the normal range. And every time she was told that, look, your thyroid is fine. You don't need to worry about that. But clinically, she was completely fitting the picture. I just put her on 25 and then increased it to 50 microgram. And trust me, she came to me after 3 months and she says, my life has changed. I'm back to what I used to be. Her TSH was still in the normal range, but this time, if I remember correctly, it was between 1 to 1.5, something like that. So that's what I'm saying, that we are usually fixated on those numbers, but we need to remember there are people who are normal out of those ranges as well. Now, coming to the first part of the question, whenever I receive referrals, they come with T3 and T4 turn already, most of the time. But to be very honest with you, I've never thought about it. I just do what is right for the patient.
So in my scenario here, would you start the patient on T3 or?
I will just, if it's low and they are like clear symptoms, there is no, obstructive sleep apnea, there is no iron deficiency, there is no other issues, for example.
But these are people, they've got thinning of the eyebrows, they've got very dry skin. And
No, I think these are non-specific symptoms.
These are, and no, I've tried 2 of my patients with T3 with their informed consent, and they've all come back to report they feel they've got more energy now.
Now, always remember that T3 is like a steroid.
Hmm.
Okay, so if you give it to anyone, they will be feeling great because they make them hyperactive. But you have to select the patient very carefully. If you give anabolic steroid to any male, they will feel amazing. They'll be like Superman. But we need to realize that we select the right people. It's like amphetamine, So I think the response is not the thing for me. For me, it's selecting the right person for it. Yeah.
All these timeless patients go to naturopath and get the T3 supplement. What do I do?
Yeah.
Yeah.
That means you're working.
To be honest with you, I have this big problem with the naturopaths. That whenever the patient comes and tell me that naturopath has given me this thing, I just say, look, fine, let's not talk about that. I say that, if there is any science behind it, I would, happily do what the naturopath is saying. But what I'm telling you, there is a lot of science behind it. So I try to convince them, and I must say that most of the time I'm able to convince them. But if I feel, as I say, that there are signs or symptoms suggestive of that they definitely need T3, then I do it. You had the same question?
Yeah, but what's the reverse T3 mean? They always ask, please, they happy to pay for it.
Reverse T3 has no clinical significance at all. The only clinical significance of reverse T3 is in a sick patient where you cannot identify during that sickness that this deranged thyroid function is because of sickness or is it primarily deranged thyroid function. And if you do reverse T3, if it is high, then it is euthyroid, sick euthyroid. And if you have abnormal thyroid function in a sick patient with a reverse T3 that is low, then it is not sick euthyroid. Then it is a primarily thyroid problem. For example, someone is having a pneumonia in the hospital and you did a thyroid function test, and they are absolutely abnormal. And I'm not sure whether I should treat it or not, because I don't know whether this tachycardia and all this stuff is from, obviously it's from pneumonia, but the patient is shaking as well. So I will just do a reverse T3 to answer that question. Otherwise, there is no clinical significance at all.
The other question is about pregnancy and the thyroid
Yes.
hormone level is different. So how do you distinguish when it's normal and when you're supposed to treat?
So most likely, okay, always remember that pregnancy is an immunocompromised state. And any autoimmune problem will go into remission in pregnancy. So it's extremely rare than rare that you will diagnose Graves' disease in pregnancy. Okay? Most likely it will be transient thyrotoxicosis of pregnancy. And I'm not worried if the TSH is suppressed. There is tachycardia in pregnancy anyways. However, if the patient is losing weight rather than gaining weight, then I'm worried, because that means that is the thyroid causing it. And most of the time, I will not treat it. I will sit on it. And after 16, 18 weeks, you will start seeing improvement in the thyroid function. Because you remember it is the beta subunit, sorry, the alpha subunit of the TSH, which has the same structure as the beta HCG. So the beta HCG is actually going to the pituitary alpha subunit and producing TSH and mimicking as TSH. And that's how your thyroid function goes up. So that's the normal physiology, because HCG goes in, hundreds and thousands of number, So I would not usually jump on it and treat it, even if the TSH is suppressed. Coming on the other spectrum, hypothyroidism, yes, we should treat that with thyroxine, because we know that kids who are hypothyroid when they're born, they have less IQ, they have delayed reflexes, and the newborn or the fetus is dependent on the mother for thyroxine till the 18th week of pregnancy, and after that the baby starts producing its own thyroxine in the thyroid gland. So in the first 18 weeks, it's very, very important that you keep the TSH according to the local lab values. If you do not have value, keep it below 2.5 in the first trimester. I mean, in the first trimester, and then between 2.5 to 4 thereafter. Any questions? Good. Now, I just want to take this opportunity to share with you. I was just talking to some of the colleagues on that table. Share with you what I want to do. That's the ambition I, carry with me all the time, and I think it's going to, come to life soon. So what I'm trying to do is I'm trying to develop a center which would be center of excellence for obesity. And what I'm trying to do different here is that I'm developing a research arm to that. And I'm trying to do treatment which would be patient, specific and customized. And that treatment can vary from pharmacological agents. It could be dietitian-based treatment. It could be exercise physiologist. It could be bariatric surgery. And when I say it's patient specific, that means that we will go down to the level of calculating the basic metabolic rate of every patient at rest and at exercise, to give them very customized diet plans, which means that we will be measuring their rest and exercise basic metabolic rate through calometry, both at rest and exercise. We'll be measuring their VO2 maxes. I'll be doing their body composition scans, because I do not believe in BMI. So this is something I'm doing. And just to support this by some research, I'm doing 3 clinical trials with Eli Lilly and Novo Nordisk, in which I am inducting patients for these studies. And the inclusion criteria is pretty simple. anyone who has a BMI of 35 or above. There is no cost involved for the patient. They should not be on any incretins in the last 6 months, which means, sorry, in the last 90 days, which means no Ozempic, no Trulicity, no DPP-4. There should not be any history of bariatric procedures such as sleeve, gastric bypass, or anything like that. And if they are diabetic, we can induct them, but they should have one diabetes-related complication in the form of any micro or macrovascular disease. And there should not be any retinopathy because there is some literature about the development of or worsening of retinopathy with the incretins. So one of the trial I'm doing is on a triple agonist, which is GLP-1, GIP-1, and a glucagon agonist. We haven't given him a name yet. We call it an investigation product. And in the phase 2 studies, we have seen it has produced some amazing results, which I cannot share because of the confidentiality. Another drug is called an amylin analog, which we are trialing and combining with semaglutide, which is a GLP-1 analog. And we have seen that in 26 weeks of therapy, you can get the same results or even better results than Ozempic 1-year therapy. So these are the 2 drugs. And then there is another drug that we are trying, which is a messenger RNA blocker. And we are using that for hypercholesterolemia. So most of these trials will be activated in the next couple of months. So I would urge you to please reach out to me on, my details. If you have any patients that would benefit from these trials, there is no cost involved. There will be a proper screening process. And if they consent for the trial, we will conduct them. They are RCTs and double-blinded placebo trials. I don't know whether they go on placebo or they go on the investigation product. No one will know until the trial is completed. Any questions about these? Yes. Sorry?
Is there something that is a mystery?
Yes, so unfortunately, till the trial is activated, I'm not allowed to, release it in a paper form. That's why I'm just verbally telling you. But please note down the details, and you can always check with me. The gross criteria is BMI above 35, should not be on any DPP-4 or GLP-1 in the last 90 days, no previous bariatric surgery, and if they are diabetic, there is no BMI limit if they are diabetic, but they should have one diabetes-related micro or macrovascular complication excluding retinopathy. And obviously type 1s are not included anyways. So these are the basic, gross criteria, and anyone who fits certain, somewhere around this criteria would be eligible.
There is a question I've got here from the chat, which is, do you know anything about the use of naltrexone in thyroid disease? I have a patient under an integrated GP in Victoria who has been prescribing this, and I don't understand why.
So the question is the use of naltrexone in thyroid disease. Unfortunately, I do not have any knowledge, of use of naltrexone in thyroid disease. However, it is used for obesity treatment, but I don't know why it has been. And to the literature I know, I've never come across this as well.
We know. It's levothyroxine is used for hashish. I think it's reduced inflammation.
Okay, so two of my colleagues are saying here that it is used to reduce inflammation in Hashimoto thyroiditis.
I'm not sure who that is. Someone in the Zoom world.
Can I ask you about obesity and sleep apnea problem? How do you treat that?
Weight loss.
No, what I meant, I know what you're not getting, but he's got problem with sleep apnea, he can't function even.
Yes, so this patient needs to be on a very, very, aggressive weight loss management plan. which needs a multidisciplinary approach. However, the least we can do for this patient is to put him on Ozempic. Yeah, and if he can lose 8 to 10% of his body weight, he'll be a different person.
The sleep, the CPAP won't happen first.
CPAP definitely will help the quality of his life, but it will not actually solve the problem. The complication that he's at risk of from OSA, like the right-sided heart failure, pulmonary hypertension, the risk of stroke. So the studies have shown that CPAP, it just improves your quality of life, but it doesn't have any mortality benefit.
So you should lose his weight first.
Absolutely.
Or if you weight hard and you can't, that's what he says, put on weight.
Sorry?
He says he's very tired and that's why.
He's tired because his brain never sleeps.
Yeah.
Because he's up all night, he doesn't realize that. He only realizes it when he wakes up in the morning tired. And if you don't want to use Ozempic, just wait for 3 weeks, you will have terzipatide, which is even better than Ozempic.
Because he doesn't want to go to obesity clinic, so that's why he wants to get treatment for his sleep first.
So he needs to understand that his sleep apnea will never get better unless he loses weight. Yes, and also I can tell you his testosterone would be low as well. His testosterone would be very low as well.
Is there any contraindications of things that we have to look out for at this new drug?
Terzipatide? Look, it's an incretin. Most of the safety and the contraindication is as similar as Ozempic, absolutely. Because these are all gut hormones and they have the same side effect profile.
What's it called, sorry?
Terzipatide, they love to call it Mounjaro.
Okay.
In what way is it different to Ozempic?
Oh, it's excellent
Can
data.
you spell it?
Sorry?
Can you spell
Mounjaro.
And it's not a BBA.
It will never be BBS because it costs money.
It's being.
So I think it's a good, PBS, look, I think someone needs to, like the big influential organizations such as the RACG, the General Practitioners College, the Physicians College, AMA, we need to ask the question now. Because let's say 5 years ago, if you ask the question from Medicare, like put these medications, for example, Geromine or Orlistat for weight loss on PBS, I think the time was wrong to ask that question. Now I think it's the right time if these influential bodies ask this question and they start to lobby for Ozempic or Terzipatide, because we now know from the trials that there is mortality benefit and the weight loss is actually equivalent to bariatric surgery. So, and we now know that there is a recent study published from Victoria in which they trialed in a small hospital in not Victoria, it was in New South Wales, in Blue Mountain, where they trialed a tertiary level obesity multidisciplinary service for 3 years. And what they did was they actually recruited patients through ED who were obese and they were coming because of obesity related health problems. And they inducted all those patients into their obesity tertiary service. And after 3 years, they looked at the data. So the presentation to hospital in those 3 years was reduced by a big number. And the amount of dollars that they saved over those 3 years was, I think, in circa of like $11–12 million when they, plotted to the whole population. So I think with these drugs, someone needs to ask the right question now at the right time, which is now. At least for patients, like, I know testosterone is low in most of the, patients, but not everyone goes with testosterone. There's a specific criteria. So I think that there should be a criteria where you are morbidly obese with a lot of comorbidities. These patients should have subsidized treatment for these agents, such as your patient. Because, and depending on the age as well. So I don't know, may happen. But now, UK Prime Minister has allocated 40 million pounds towards these drugs to the general practices so that they can have easy access to these medications, because they truly believe, which is very good, that it will reduce their hospital presentations and the expenditure in the hospital. I think Australia will follow at some stage, but I don't know yet. Your question?
Will go be any plans for that, and then what your thoughts between the two?
Manjaro is a better molecule, no doubt about that. If you have both, go for Manjaro. If you can't find, obviously Ozempic is something to go for then. Now, to give you a little example that 1 in 3 patients will lose more than 20% of their body weight if they are on tirzepatide. Thank you. Yes. And 50% of the patient will lose 50% of their body weight. 15% of their body weight if they are on tirzepatide.
So how long do they need to stay on this medication?
So the trial that was done was 56 weeks.
And what happened to them after?
So that is another opening discussion happening in the whole, academic society now, that we need to now recognize obesity as a chronic condition. It's like diabetes, it's like hypertension. If you stop Ramipril, the blood pressure will go up again. Right? Now they might stop losing weight because, obviously they can't disappear from Earth. So, but they will plateau, and they will, if they are responders, and they will plateau at a stage where their body is, moved into a metabolic switch with the help of these medications. Because remember, your hypothalamus is still watching you. The moment you stop this drug, it's going to attack you. It's going to bring you back to your set point. And the hypothalamus knows how to do it. Do it very quickly. So that's why I always tell my patients, it's a never-ending battle. You have to be on your toes. Or if your patient is so good that after using it for a year, they can fight it out with an extreme program of exercise, strict diet. I mean, the example is that in the studies we have seen that, let's say if you lose weight and you reach to a very, decent weight for your body. Now for that amount of weight that you're carrying, if you eat 500 less calories, you will maintain that weight. But again, it's the thing of discipline and sticking to the plan, which I think in this busy lifestyle, it's very difficult. Time to go home.